Hello, this is the self-study on otitis externa and media. And what we're going to be doing is describing the epidemiology for acute otitis media. You'll understand the pathogens and the presenting symptoms and physical findings. Understand the American Academy of Pediatrics guidelines on how to diagnose and manage. We'll also be talking about otitis media with effusion, which is a little bit different, and how to manage, and then the presenting symptoms and how to treat otitis externa. The required reading is from Nelson's Textbook of Pediatrics, chapters 105 and 106. So the first thing is to understand some simple definitions. And when we're talking about ear infections, we're looking at effusion. So liquid in the middle ear cavity would be a middle ear effusion. Acute otitis media is rapid onset of signs and symptoms of middle ear inflammation. If you have 3 or more separate episodes of acute otitis media in 6 months, or if you have 4 episodes within a year, with the last one at least in the past 6 months, then you have what's called recurrent acute otitis media. Otitis media with effusion is middle ear fluid that is not infected, so you just have some serous fluid behind the middle ear, behind the tympanic membrane. And external otitis is inflammation of the external auditory canal. You're looking in front of the tympanic membrane. So here's our first case. We have an 18-month-old boy. He has no significant past medical history, and he comes to your office with a cough and runny nose for a week. I'm really sorry if that picture keeps coming up in the slideshow. And then he develops fever yesterday afternoon. Mom says he had trouble sleeping last night. He had a poor appetite this morning. And you notice on our little guy here that he's got a fever of 102.5. He's crying on his exam, but he's consolable. He just looks like he doesn't feel good, but he's not really what you would walk in and acutely think, oh my goodness, is he sick? So that's why non-toxic. Heart rate rhythm is regular. Lungs are cleared to auscultation bilaterally. HENT, he has he's normal cephalic atraumatic with his skull, clear conjunctiva. In his nose you see clear nasal discharge. Oropharynx is clear. His ear canals are patent. His right TM is clear, but in his left TM you see this. All right, so you have this red and weird looking eardrum. So what are we actually looking at? Well, we're looking at an erythematous tympanic membrane. It is bulging, so this is bulging out at you. It is immobile with insufflation. These are the times that you actually want to use your insufflation bulb to see if that eardrum will move at all. And so remembering just a review of normal anatomy, when we are talking about the otitis media, again, we're looking behind the tympanic membrane at fluid that is in the middle ear and can then affect the bones of the middle ear. It can affect hearing. You don't see that nice cone of light which you're seeing in that picture to the right, which is a normal eardrum. The other thing that happens is the eustachian tube is also connected behind the tympanic membrane, so fluid can collect if your eustachian tube is inflamed for any reason. Okay, and this young man has acute otitis media. This is actually the most common condition where we're using antibiotics in pediatrics. Because of immunizations, the number of visits for acute otitis media have been decreasing, and therefore prescriptions to pediatrics have been decreasing, and that's a good thing because of drug resistance from using too many prescriptions for viral infections. If you look at the difference between kids and adults, you're going to see that the eustachian tube in a child is much more horizontal than in an adult, and that leaves the child at risk. So anytime there's a runny nose, you may have fluid actually come back. If a child's been given a bottle at bedtime, you can see where the child swallows, you can get this fluid going back into the ear, whereas with an adult, it's at a more acute angle. So therefore, the peak age for acute otitis media is actually 6 to 18 months. And that's, again, because most of their diet is coming from liquid and not from solids, and so you have this chance of fluid going back into the eustachian tube. Race, there's an increased risk in Native American, Alaskan, or Canadian Eskimos, and Indigenous Australian. There is some family history, and boys seem to get this more than girls. There are some modifiable risks, so things that may put you at risk that you can take care of. If you have out-of-home daycare, so you're exposed to more germs. If you're being fed formula because the baby's head may not be held at the right correct angle, which is at the angle of where the baby would eat from the breast. Any tobacco smoke exposure, because the eustachian tube will get irritated as well as the nasal mucosa. Poverty. Again, that has to do with more use of formula, actually, not having the proper, I'm going to put air quotes around the word toys, but it's equipment for your child to have them sitting up. Maybe you have several people sharing the bed. You have a dusty environment, whatever. Winter, because the windows are shut. So again, you've got more dust in the house. Pacifier use, and immunization deficiencies. And then there are some craniofacial abnormalities that would allow for formula or breast milk to go back into the eustachian tube and into the middle ear. Pathophysiology usually starts with a viral upper respiratory infection that then leads to inflammation of the respiratory mucosa, that then obstructs the eustachian tube, that then causes negative pressure and mucose secretion accumulation, that then leads to colonization, and then bam, you have your acute otitis media. Pathogens, primarily strep pneumo and Haemophilus influenza. And we're seeing a drop in these bacteria because of immunizations. Bilateral acute otitis media is primarily from the H flu. Moraxilla is kind of creeping up there. Again, we're not immunizing for Moraxilla, so we may see these numbers change in the future. And then group A strep kind of picks up the rest of them, but it's usually with older children. Viruses, primarily respiratory syncytial virus and rhinovirus, although we can see this with the flu, metapneumovirus, and adenoviruses. Signs and symptoms, these are usually nonspecific, especially in infants. So we get these general, I don't feel good kind of symptoms. Fever, poor appetite, poor sleep, vomiting and diarrhea, and irritability. And you can see these symptoms if the child has a sore throat, if they have pneumonia, if they have a urine infection. It all comes around the same nonspecific signs and symptoms. However, what comes across with acute otitis media is ear pain. And ear pain is the most common complaint, even if the child can't speak. Although ear tugging has low sensitivity and specificity, you may have your child pulling at their ear, or they don't want to lay on one side because their ear hurts. Diagnostic criteria, we need to have that middle ear effusion, and so your TM is opaque, there's decreased mobility, and there's air fluid levels. The tympanic membrane is bulging because of inflammation, so you need to have moderate to severe bulging or pain and discharge, or mild bulging with pain or intense erythema, and we'll show you some pictures in a bit. It's usually not this obvious, but you can see the spectrum from normal tympanic membrane to severe bulging, which our patient had. I am not going to play this video, but I do recommend that you go to this YouTube site. This video, I'll see if it'll work at all. Yeah, all right. Does show you an air fluid level with the first video. It then goes on to showing bulging tympanic membrane. You can see the insufflator bulb. You can look at how this membrane is moving. That's because they're puffing the air. This is a bulla, that thing that looks like a blister. And I guess I'm lying, I am showing you all of this. The fourth is, this is resolution of the otitis media, and look at how much more that tympanic membrane moved with air. This is an air fluid level. Still, you can see some bubbles off at about 3 o'clock, but you have better movement of the tympanic membrane. This one is a treatment failure, even though you do have some movement, highly erythematous. Here there's no change at all. You can see the bulging between 9 o'clock through 11 o'clock. And this last one is a perforation. The eardrum's not going to move much, but at about 3:30 there was a hole in the tympanic membrane. So you can go through this video and slow it down or pause it to see what's going on again. But this is a great video that shows what happens with the pneumatic bulb and how much that eardrum actually will move if you're doing it correctly. Diagnosis between severe and non-severe really depends on whether or not you have pain and a fever. So severe otitis media will have moderate to severe pain with a temperature of over 102.2. Non-severe is mild pain with a temperature below 102.2, and this is important to know whether or not you have severe or non-severe acute otitis media because of how you treat. So treatment. Do you give antibiotics or do you just observe? Well, if you give antibiotics and they don't need it, there's increasing bacterial resistance. And a lot of these kids could have done well with just observation to see whether or not it really is bacterial. The only reason you would observe is if you can follow up within 2 to 3 days from the onset of symptoms. So 48 to 72 hours from the onset of symptoms. Otherwise, you should consider treatment. So the treatment is based on the age and severity of symptoms and whether it's unilateral or bilateral and if there's a discharge. And these are from the American Academy of Pediatrics from 2013, which actually is the most updated guideline, and they are still in effect today. So you can see if your child is 6 months to 2 years, you would use antibiotics pretty much throughout. If they're greater than 2 years, you have the option of additional observation with if they don't have a discharge, if they don't have any otorrhea, both bilateral or unilateral. Okay. So you want to treat your patient with antibiotics if they have otorrhea, if the symptoms are severe, if it's bilateral, or the patient's under 2, and always if under 6 months. You can observe if it's non-severe and it's unilateral and the patient is less than 2, or in any case if the patient's greater than 2. But if you choose to observe, you must follow up within 48 to 72 hours of the symptom onset. And that's also important to know. That's a good board question. How do you treat? First-line antibiotics are high-dose amoxicillin by mouth. And you really want to make sure you're telling your patient by mouth, because there have been patients that will put their amoxicillin in their ear. High dose is 80 to 90 milligrams per kilogram per day in 2 divided doses. If they're penicillin allergic, you better know what their reaction is. If they're not anaphylactic, if they just have a rash, you do have the option of using cephalosporins. If they're anaphylactic, then you want to look at your azithromycin or clindamycin. Levofloxacin has been used, but it's off-label, especially with younger children. And it's important to know that azithromycin has limited activity against the 2 most common bugs, which are the staph pneumonia and H. flu, if they're resistant. Second-line antibiotics, so what we're talking about for second-line is a child who may have had their otitis media resolve, but it's been within the last month, or if they're coming back in for follow-up and they haven't had any improvement, or your parents or you know that they're not responsive to amoxicillin. Then you're going to use amoxicillin clavulanate or Augmentin. Or you're going to use a second-generation cephalosporin if they are allergic. And again, we're using 90 milligrams per kilogram per day of amoxicillin in 2 divided doses. This will cause diarrhea, so it's important that you let your parents know that the child is going to have diarrhea from the antibiotic, and to give it with food if possible. Duration of treatment, standard of care is 10 days. We can get away with a shorter treatment as our child gets older, but you will see most physicians using a 10-day course. And then you follow up in 2 weeks. And again, that's pretty standard. Here's your antibiotic for 10 days. Come back in 2 weeks. I want to see if this resolved. You're going to be treating the pain with acetaminophen or ibuprofen. And you can use a topical benzocaine and antipyrine drop, which is wonderful to get rid of pain. So this goes into the ear as opposed to the ibuprofen or the antibiotic. There is such a thing as an otitis conjunctivitis syndrome. This is an exception to observe. You must treat with antibiotics. It is usually an acute otitis with purulent conjunctivitis. It's usually caused by H. flu, and the treatment here is high-dose amoxicillin clavulanate, first drug of choice, as opposed to just high-dose amoxil. This is a wonderful time to also use OMM. We can help open up the eustachian tube with the Galbraith technique, which is noticed here where our patient is sitting or supine. We have the affected ear facing away from us, and we apply downward transverse force on the mandible, so we're crossing the face and kind of opening that eustachian tube. Hold it through 3 to 5 seconds and then repeat for either a half a minute to a minute. It's extremely effective. Prevention, we want to encourage exclusive breastfeeding for at least 6 months and avoiding exposure to tobacco smoke. I've found that most of my treatment failures have been in homes with smokers. We want to make sure we're giving the pneumococcal and H. flu vaccine. We want to provide annual influenza vaccine. Again, you're trying to prevent the upper respiratory infections which cause the congestion. And if children are older, you can help with some xylitol lozenges, but you don't really want to use that in younger kids because of the choking risk. It also tastes pretty nasty. Oops, sorry. Complications, you can perforate the tympanic membrane. You can get sclerosis of the middle ear bones as well. Hearing loss from middle ear fluid and from the tympanosclerosis. Sometimes balance problems if it really gets into the middle ear and goes beyond. Cholesteomata, mastoiditis, and rare in the United States, intracranial complications. This is cholesteomata being demonstrated here, and that we talked about last year, but the cholesteomata can grow and eat through the tympanic membrane. Oops. All right, so our next case, we see our 18-month-old who we treated, and mom says fever resolved and he's doing really well, and you look in his eardrum and you see this. And so you've got this fluid behind the eardrum, but the eardrum doesn't look bad at all. So, oh my gosh, you're saying, why did you have him come back so soon? Because, you know, this isn't really cleared up. Well, what we're really looking at now is otitis media with effusion. So this is asymptomatic. There's no signs of acute infection. There may still be some hearing loss, again, because there's fluid behind the tympanic membrane. Ear pain or maybe fullness. Your child may have some dizziness or ringing in their ears. And again, we're going to see decreased mobility of the tympanic membrane with insufflator. Treatment, we just watched this one. It commonly resolves spontaneously, but it can take weeks to months. We don't recommend medications, although some physicians will use either antihistamines or decongestants, but these are not recommended in pediatrics. Why would we send someone for a hearing eval and referral to otolaryngology? For tubes, if we need to drain this fluid, is if we have the otitis media with effusion for more than 3 months, if the child is at risk for speech or language or learning problems, or if they have a persistent hearing loss at greater than 40 decibels. And what will happen is they will put in a tympanostomy tube, drain the fluid. The tube then will normally just work its way out of the eardrum and will cure itself. So our next case, we have a 15-year-old male with no significant past medical history who has severe right-sided ear pain, which is aggravated by chewing. He went swimming in Lake Tahoe 1 week ago, and on examining the right ear, there's tenderness when you pull on the pinna, and this is what you see under with your otoscope. Okay. So this is the external ear on the left, and as you're going into the canal on the right. And we're looking at otitis externa, which is also known as swimmer's ear. And this is inflammation of the external auditory canal, most commonly from infection. So it is in front of the eardrum, and it is extremely painful to try to look in the ear and see. What's happening here is you get a breakdown of the skin cerumen barrier, which then causes inflammation of the skin, edema, and some itching. It allows for an increased pH of the ear canal in an alkaline warm environment, which leads to bacterial or fungal growth. And then you get pain. Risk factors are excess moisture, so usually in swimming, but if you have people that take baths and like to dip their head into the water, trauma to the ear, and some skin conditions. Pathogens, here we're looking primarily at Pseudomonas if you're thinking bacterial, although we can see some Staph epi and Staph aureus. Fungal is about 2 to 10%, primarily Candida and Aspergillus. Signs and symptoms here for diagnosis, we're really going to have a lot of ear pain and itching and a discharge. There's hearing loss because you're not getting air conducted into the tympanic membrane onto the tympanic membrane at all. So the ear is essentially blocked. Physical exam, swelling of the pinna can happen, but mostly it's tenderness when you go to palpate the ear. Edema and erythema of the ear canal, and then you get this clumpy white ear discharge. Treatment here is a topical antibiotic. Usually it's a fluoroquinolone, but it can also be a combination of medications, so polymyxin with neomycin and hydrocortisone. You can use aminoglycosides. You can also use the same benzocaine drop to try to help with pain, but you want to get the antibiotic in first. And the bottom picture is actually showing you what's called an ear wick, like a candle wick. If you can think of this as a little ear tampon, what you're doing is putting a little cotton into the ear, and the antibiotic goes on the cotton, which then makes the cotton swell and hold the antibiotic against the ear canal itself during the time that you need to apply the antibiotics. If you don't have this ear wick, then you have your child or adult hold their head at a slant like the picture. They have to hold their head that way for 10 to 15 minutes after the drops are applied. And then I tell my patient to put a little cotton in their ear so that when they lift their head back up, their medication is not falling out of the ear. For pain, we use ibuprofen or acetaminophen. Follow-up is there's usually improvement within 2 days, but if you're not seeing any improvement within about 5 to 6, you want to culture the discharge or refer to ear, nose, and throat. You also want to consider fungal causes, and the treatment there would be clotrimazole. This is what fungal will look like as opposed to the goopy white. Prevention, leave your ears alone and keep them dry. So there is such a thing as copper tone swimmer's ear prevention, which is actually a combination of acetic acid and diluted isopropyl alcohol. But you can use a combination of distilled white vinegar and water, or distilled white vinegar and alcohol. You want to do it 1-to-1. I like mixing them both, so equal amounts of vinegar and rubbing alcohol. The rubbing alcohol helps it evaporate quicker. The acetic acid is what normalizes the pH and kills the germs. Another old home remedy is blow drying. So once you're done swimming or showering, you put a blow dryer close to the ear, on low, please, and dry inside the ear canal that way. All right, so a couple of things now. What are you seeing here? If you answered air fluid levels with bubbles, you would be correct and look between 9 o'clock and noon. You're seeing the air fluid level at about 9 o'clock, and then air bubbles going up through 10, 11, and 12 o'clock. Here, what are you seeing? This would be otitis externa. Note that you're getting a real erythematous canal. You're not able to see the tympanic membrane, and you've got that otorrhea. You've got this nasty, thick, white discharge in the canal. Here, what are you seeing? Externally, this is what an otitis externa would look like. You expect to go into that canal and have pain. You've got this serous discharge. This will sometimes be foul smelling. It's usually thick and will crust on the ear, but this is what the otitis externa will look like on the outside of the ear at times. Here, this is a severe otitis media. You've got hyperemia of the tympanic membrane with tremendous bulging. Here, you have otitis media, but this is not with a serous effusion. This is pus behind the tympanic membrane. So this is an acute otitis media with an fluid level, but this is pus, not nice serous fluid. And what is this? And hopefully you all knew that this was my ringer, and this is a normal tympanic membrane. So thank you much. If you have any questions, please don't hesitate to let me know. You can just give me an email, and I look forward to working with you the rest of this semester. Thanks.